Then only after 5 days, if these patients have cytokine storm in form of oxygen saturation coming down, fever coming up, or raised IL-6 or raised cytokines that we're now monitoring, raised ferritin and so on, these patients get steroids. And of course, in addition, we give anticoagulants. In the first week, also, monoclonal antibodies are supposed to be effective. Unfortunately, not commercially available in India. Some studies in US initially showed they're effective. In fact, President Trump got this. But some later studies recently where they're giving it in the later part is not effective. Similarly, convalescent plasma, in our opinion, has been very effective given within 5 days. If we give it later, as some of the studies have done, is not going to be effective. Other antivirals, we haven't had so much experience, but like favipiravir and all are supposed to be effective. In between period, colchicine could be used to decrease the inflammatory response. Our overall experience, tocilizumab hasn't been very good, although the recent New England Journal study, which suggests that given in the right time, in right group of patients, it can be effective. But what is more interesting is this, that a recent study, again from New England Journal, showed that this baricitinib, which is a JAK1, JAK2 inhibitor, which decreases the inflammatory pathway, is much better than steroids in the sense it does not produce so much immunosuppression. And this study, and I think future treatment, I think is going to be a combination of remdesivir with baricitinib, because baricitinib is less harmful than steroids. And if you can combine both these drugs, and this study again just published 3 days back in New England Journal showed efficacy which is quite high, and that may become the future method of treating these patients. Of course, low mortality in our country may be because of a variety of reasons, and I said in our own institute it is less than 0.5%, which is because of several reasons. Again, I don't want to go too much, but asymptomatic carriers are a problem for us, and I think the best way to guard ourselves, because we don't know whether the patient is symptomatic or not, is masking, physical distance, and hand washing. I think the word social distancing is wrong. We must have physical distancing. Among masks, again, I don't want to go into the details, but even if you wear a standard cloth mask, it may be okay. N95 is easily available to us. There are many uncertainties, but I want to concentrate a little on what is happening in terms of what is changing. I think this teleeducation is becoming much more common, like what we're doing. We're reaching larger number of people. Telemedicine is coming back again into being. But when will we reach the new normal? The new normal will reach only after the vaccine comes. And this vaccine is going to take a few months from now. But this vaccine has become a very important topic. So next 3 or 4 minutes I'll spend on the vaccine. The COVID-19 vaccine, I think, is a miracle of science. Vaccines usually take 5 or 6 years minimum to be made, sometimes 15 years, but everything has happened within 9 months. When it started initially in February itself, people started putting vaccine candidates, more than 300 candidates. 48 of these went into clinical trial, and 6 of these have completed phase 3 trial, and 5 of these vaccines have got government approval. First government approval came for Pfizer vaccine in UK, later in US, later other countries like even Saudi Arabia, Bahrain, Singapore, Germany, all have approved Pfizer vaccine. Moderna vaccine is now approved in USA, and in China and Russia, the local vaccines have been approved. So totally 5 vaccines have been approved by different governments officially. In India, it's believed that a vaccine approval based upon what recent government officials are saying would come somewhere in the middle of January, most probably the Oxford vaccine, sometime in the middle of January, so we can start a vaccination program. Now, these vaccines, we have had again some experience with these vaccines. In fact, we did the phase 2 trial with the Bharat Biotech vaccine, very good response, no allergies, and we're now doing the phase 3 trial with the Sputnik vaccine, which is again has good response. But just briefly, again, this is a question that is asked with us very commonly from many of the physicians. We have several types of COVID vaccines. The DNA vaccine I won't go into because the Innova is still not available. The main vaccine that's available is RNA vaccine. It's very simple. RNA particles from the virus are made into lipid and they're injected into the body, where the RNA, taking help of body ribosomes, produces the spike protein, and this spike protein causes immune response. And it's because it's only pure spike protein, very few side effects. Most of this time, the Pfizer and Moderna has local side effects. Pfizer has produced some allergic reactions, but there are no contraindications except with patients with severe allergy, and of course, pregnant at the age of 16 years. So these are the 2 vaccines now approved in US. They are probably the best vaccine, but the problem, of course, is Pfizer vaccine, the cost is very high. It has to be stored in -70, Moderna in -20. So in our country, this may not be the vaccine that we're going to use. The best vaccines are going to be protein vaccines. This is peptide vaccines, which are going to be available somewhere from June to July in our country. These are cheap, they're very safe, long-term efficacy has been proved. They are being made by two companies now. Novavax is going to be available somewhere from March. But the main vaccine our country is going to get in protein vaccine is a Baylor vaccine from Bharat, Biological Evans is tied up with Baylor's, and by June they're going to release this vaccine, and I believe in long term this is going to be the vaccine that our country is going to use. The third type of vaccine is a vaccine where the virus is inactivated, and this inactivated virus is a standard technique that has been used. The main vaccine is the Chinese vaccine, Sinovac, which came from this. But also, I think you should be proud that Bharat Biotech is inactivated virus vaccine that has been made in our country by research from both ICMR, the Pune Institute of Virology, and Bharat Biotech. And this vaccine now is in phase 3. And our own experience of this vaccine has been very good. The last vaccine is a vector vaccine. This is a very interesting vaccine where an adenovector of chimpanzee is taken. This is not very virulent. And onto this is added the spike protein of the coronavirus. And this vaccine is again very effective. All these vaccines have to be given in 2 doses, in 3 weeks or 4 weeks apart. And the 2 vaccines that are commercially available as adenovector vaccines are Oxford vaccine, which phase 3 trial in our country is going to be produced by Serum Institute in Pune, and the Sputnik vaccine, which is going to be marketed by Reddy Labs. They're making it. Reddy and Hetero Labs are making it. And actually, we are doing the phase 3 trial for them. And this also is supposed to be very effective based upon the phase 2 trials that have come from Russia. So I just spend a little time on these vaccines because I think this knowledge is very important for physicians. You'll be coming across this. But the interesting publication, the major publication has come from Pfizer vaccine, which is the RNA vaccine. And you can see this, the RNA, which is the virus RNA is injected in lipid nanoparticles, goes into the cell, and ribosomes, using the body ribosome, converts into spike protein. And this spike protein, which is produced, has a reaction from the body, both in terms of B cells, antibodies, and T cells also. And you can see the study, which was published in New England Journal just a week back, 95% efficacy. A placebo, 162 patients compared, this is about 40,000 patients were tested, and only 8 with the vaccine, and they had mild disease. So not only is the disease mild, but you never get severe disease, protection is in 95% of the patients. So this is now completely proved. Now coming to the last aspect, what is going to happen beyond COVID? What will be new normal? I think all of us have been shaken by this. But my personal belief is that as these vaccines take into effect, by end of next year, end of 2021, we'll start forgetting about what happened. We'll have memories, of course, but we'll not have the bad memories that we're having now. Things will change. The world will look a little different. We'll still have long COVID with us. The long COVID is going to stay with us. We have to now concentrate, do our research on that. As more and more patients come with interstitial lung disease, rheumatoid type of problems, with anti-nuclear antibody positivity increasing in the population, we're going to get this, how to deal with it. We have to come with new protocols, a lot of research. I think even in India is going to occur. This has changed the thinking completely. See what happened before COVID, when somebody was wearing a mask, everybody used to stare. What is wrong with this person? And now after COVID, if somebody is not wearing a mask, we're all staring. So these masks, in my opinion, are going to continue for the next 6 months. But I think slowly over a period of time, we're going to get used to it, and we'll get out of this phenomenon. And I think finally, what this COVID has taught us is that we are all interconnected. Every part of the world is now interconnected. No man is an island entire by itself. Every man is a piece of a continent of the main. And I think this interconnection has become very important, as we have seen recently how a small episode was described in Britain, and suddenly everything was cut off. Britain was totally cut off from the rest of the world. So these episodes are going to come. And I think what COVID has taught us, and this is what I keep telling people. Everybody says, oh, COVID has caused this problem, that problem. COVID has a lot of positives. The positivity COVID has taught us is that we're all interconnected, that we should not tinker with nature. And more importantly, science can be fantastic. The science of COVID now has taught us so much, everything, virology. I mean, even lay people are starting to read this science. It has started how vaccines can come very quickly. And if this mRNA vaccine experiment is successful, we can conquer any disease in future because these mRNAs can be refashioned. In fact, if the new virus comes, in 45 days, we can make a new mRNA. So this type of knowledge, this type of advanced insights have occurred, and these are all the positive aspects of COVID. Thank you very much for your attention.
So thank you, sir, Dr. Nagesh Reddy, for that wonderful presentation. You have given and shared so many good points and practical points. I think, Dr. Nagesh Reddy, you will have to give this in all WhatsApp groups, especially for the doctors group, because certain misconceptions and misunderstanding is there in doctors groups also. So whatever you have given, all excellent points. And only two things are bothering. You said the person can spread the virus through fecal route. So how long it can spread and how do we prevent? Because when you do a test, will it be positive? When you do RT-PCR, it will not be positive. Then for every COVID patient, do we have to do, and what precautions apart from the toilet, we close the lid and then flush? Anything else we can do? That one. And then microbe. You have said about microbe. That is also a point which gut microbe, because I am a passionate person for microbe. I asked you to give a talk also last time, and you said you prepared a nice talk and then you spoke about gut microbe. So these two aspects you can expect. I think Dr. Sarin has also come. Very nice. So after your these questions I will ask Sarin, and please allow me to go because I have a webinar at 7:45. So in the meantime, I'll ask 2-3 questions and I'll leave to Sangaram. Now first Nagesh Rao Reddy, please.
Thank you, Dr. Munnan. I think this is a very important question that you asked. This virus is present in the feces for a long period of time, longer than respiratory secretions. And it's shed in the feces for up to 6 weeks. Now, the significance of this is still not clear. Feco-oral route of transmission has not been demonstrated. Whether this occurs or not, we are still not sure. But what it implies is that, as you said clearly, certain toilet habits and all these things have to be modified, because potentially you can have an infective particle in the sewage for long periods of time. Now, how this is going to be affected, since studies are there, we are not sure. Fecal-oral route. Second, microbiome. I think this is some very important data which has come from Hong Kong. Microbiome alteration, showing that certain microbiome are favorable in these patients, certain microbiomes are not favorable. Again, more data is coming. So manipulation of microbiome may be in future one method of how we are going to treat this virus, at least decrease the severity of the disease. If we can take a simple pill of microbiome and convert a serious disease into a simple mild disease, that will be very favorable. And some of this data has already come. Dr. Kuing from Hong Kong, from the Prince of Wales Hospital, has produced this early data, and they're coming up with some very interesting paper. It's going to come in Nature soon. Thank you.
Yeah, thank you. I think you are very fond of shift transfer. So people who are COVID positive, who have got immunity, can we do the shift transfer and make sure unimmunized persons can be that? So that also an area where we can develop on.
Murugan, I think in general, the stool of everybody is going to become very important. And I think Shiv also agreed with me. We have done work on giving this fecal transplantation for very severe patients with alcoholic liver disease very successfully. So we are now only knowing the value of stool. Indirectly knowing the value of gastroenterologists also, because we know the value of stool now.
Dr. Sarin sir, can I ask you 2 questions? You had talked about NAFLD, MAFLD, and then diabetes, etc. Have you come across these patients with hypertension? Because hypertension, atherosclerosis, and diabetes and NAFLD forms a common soil hypothesis. So in your cases, is there any hypertension data?
Yes, the coincidence is in 2000, early 2000, when I was in GB Fund, every patient who would go for cardiac cath, I would do an ultrasound at 7 in the morning. Many patients had valvular heart disease. Many patients were for coronary artery disease. And we were blinded, and we did several thousand. And it was surprising that those who had just valvular heart disease, just about 20%, or I think 26% had fatty liver, which is general population today, while those who were having any coronary or cardiac part had more than 70% had fatty liver. The fellow left and we never published. This was 2000. Now in 2020, there is enough data that those who have got fatty liver have early and more severe cardiac injury and death. Therefore, there is a close relation. I'll give you a simple example. The fat goes and deposits into the vessels and you have foamy macrophages which cause all the disease. These foamy macrophages have origin from liver. So therefore, there is a strong correlation of hypertension, coronary artery disease. And if your liver function has higher gamma GT, GGT, there is a more cardiac risk. If there is a higher ALT, there is a more diabetes risk.
Okay. And how many patients of MAFLD has got ectopic fat in the heart also, in the heart size? Any correlation you have done?
Yes, so there are good MRI studies where have done the pericardium and the fat around the myocardium. Close to 70% of the people, 70% have extra fat. I'll give you a simple example. If your liver has 5% fat is normal. If it becomes 6 or 7%, it is bad. About 10% is fatty liver. Similarly, muscle must have 5% fat. If it is 6%, you get insulin resistance. If your muscle has 8% fat, you have a cardiac event. Similarly, around the heart, if there is a fat, it is an additional cause, and 70% have fat around their heart. So fatty liver is a diffuse process, but easy to pick up on the liver than to pick up on your pancreas or on your heart.
Okay. Sir, what about hepatitis B vaccine? Somebody who has got MAFLD, they have not vaccinated hepatitis B. Would you advise them to have hepatitis B vaccine, or is there any role for vaccine at all in this MAFLD?
Everybody, irrespective whether you're a doctor or general population, hepatitis B vaccine is mandatory. You never know when you need any surgery, blood, or any problem. So I think this is a cheap vaccine. It is a must. We are all looking for vaccine. Dr. Nagi just told about vaccines.
Yeah.
We're all looking for COVID vaccine, but what is available, you don't take it.
Correct. So this is my passion subject. I've told so many times in the doctors forum, I talk about adult immunization at least so far about 50 times. Everybody claps and everybody appreciates. When I end of the talk, I'll ask them, how many of you have had Tdap? Only 2 or 3 in the audience. So I think we also as doctors, we should be role model, and we must start the things from our home. I think it was excellent, sir. I'm sorry, I'll request Sangram to continue because I have to go another webinar. But sir, thank you very much. It was wonderful. And Sangram, please record this and give it to me. I will put it in the ACP website so that people who have missed it can see the rare presentations by 2 giants. Thank you, Sangram. Thank you, sir. Thank you very much. Thank you.
Thank you very much.
A question for Professor Sarin is there, sir. Accidentally you detect fatty liver, patient has no problem. What is your advice to such patient?
Yes, if it is fatty liver, do a FIB4, AST, platelets, age, and you find the FIB4. If it is less than 1.3, no worry. If it is above 3.4, it is cirrhosis. Between 1.3 and 3.4, you see. And if the patient has any of the risk factors like metabolic syndrome, obesity, diabetes, I think, or hypertension, that person must be further screened. You can't ignore a fatty liver.
Any role of SGLT2 and saroglitazar are useful or not? Somebody?
Yes, saroglitazar and SGLT2 both are very good drugs. They somewhat, at least the SGLT2, they decrease the weight. They are also good for, in a way, anti-fibrotic, not evaluated enough. And saroglitazar has been adequately evaluated. I think it is a good drug for dyslipidemia as well as those who have got fatty liver disease. But none of these can achieve the target of reversal. They can 5%, 10%. Ultimate treatment remains in your weight, your diet, and lifestyle.
Yeah, from quite long back, you were telling that diabetes is a disease of liver. So what is your take on that, sir?
It is. Endocrinologists have started believing it. And once in a while, they do call me in their meeting, but they don't like me because I don't want to take their bread and butter, none of us. But it is a liver disease for certain. No doubt.
Dr. Nageshwar, sir. So if patient asks choice for the vaccine, which vaccine you advise now?
Yeah.
Pfizer.
Yes, no, if the problem is Pfizer and Moderna are the best vaccines currently because of the efficacy of 95%. But unfortunately, they're not going to be available to us, mainly because the government, I don't think, is going to approve it right now, unless they change the policy. And plus the cost factor, plus the problem of transporting this -70 or -20 all the way and then giving to up. So right now, I think the most vaccine with the highest efficacy seems to be the Oxford vaccine. The Oxford vaccine efficacy rates are a little peculiar. If you look at the Oxford vaccine overall efficacy rate, they reported 70%. But if you look at a subsector of this efficacy, it's 90%. Now, 90% occurred in a patient in whom the first dose was half and second dose was full. Now, why did this occur half by mistake? They forgot to fill it fully when they gave half and second dose was full. These patients had 90% efficacy. Now, this can be explained by one simple factor, that what Oxford vaccine is using is a vector, adenovector 8, a chimpanzee vaccine, chimpanzee virus, adenovector 8. And when they give this adenovector 8 along with the spike protein of this coronavirus, some of the antibodies are directed against this adenovector 8 also. And therefore, some of the antibodies are neutralized. So when you give a full dose of the first, the full dose of second is not effective. So what Sputnik has done very intelligently, the Russian vaccine, all they're not giving credit is, the first vaccine is adenovector 5, the second vaccine is adenovector 8. And because of these differences, the immune response is much higher, almost 90%. So this trial, we are involved in this vaccine trial with Sputnik. We'll know in a few months phase 3 trial whether it's really 90%. If it's 90%, then choice could be between Oxford and Sputnik also. Bharat Biotech also is a good vaccine. About 70%, 50 to 70 they're saying, but right now the latest data which they had preprint was up to 70% protection. So availability, I think again, Shiv may know when, because he's involved in these regulatory bodies, is probably somewhere in January, later part, we may have one of these. And my hunch is that Oxford may get its green signal, and then of course we'll have the choice of using that. But if somebody had a choice among all the vaccines, of course, mRNA vaccine would be the first choice if you had a chance.
Nagesh Reddy, sir. Among the long COVID side, the main fault is at the vascular level or thrombotic point. Yes. So is it worth giving anticoagulants or antiplatelets a little longer time?
Yes. So this is a very good point that Dr. Shivraj has raised, that because of the view of this long COVID, there is a feeling that in those patients who have a severe disease or a critical disease and recover, it may be better to put them on long term. Initially, we put them anticoagulants. Long term, we switch over to antiplatelet agents, a combination of clopidogrel with aspirin. We don't know how long. Now, again, this disease is only very short with us, but I believe that at least for 6 months, we may help to prevent long-term thrombotic phenomena and maybe unexpected myocardial infarctions or strokes in this group of patients. So this is, I think, going to be the most interesting research, where you take patients with severe disease and follow them up. One group is getting this antiplatelet agents after initial anticoagulants, and one group is not getting. And if, suppose the incidence of increased stroke and myocardial infarction is a group we're getting, then we might have to put them on long-term antiplatelets. It's a very good point.
Dr. Murugesh, anything you want to comment, and any questions from your side? We'll close because...
No, sir. I enjoyed the talks. Excellent.
So if there are no more questions, there are no questions in the chat box also. That clearly shows that both the speakers have delivered their excellent talk without any questions left behind to ask. I request Dr. Murugesh to propose vote of thanks.
Good evening, everyone. Literally speaking, I enjoyed both the talks very much. It was a scientific twist with both the subject in a different direction. I, on behalf of MISAT and API Gulbarga chapter, thank Dr. P.S. Shankar sir, Professor Emeritus Rajiv Gandhi University of Health in Bangalore, for accepting the invitation to inaugurate this virtual meet. And I thank Professor Dr. S.K. Sareen, Chief Hepatologist and Director ILBS Delhi, for accepting as a speaker and sparing his valuable time and enlightening us on this subject. I also thanked our today's second speaker, Dr. Nageshwar Reddy sir, Chairman and Chief Hepatologist, Asian Institute of Gastroenterology, Hyderabad, for sparing his valuable time and giving excellent talk. From his talk, we can make out is how much multifaceted sir is I also thank Dr. Muruganathan, sir, Governor ACP India chapter, for moderating this session excellent way. And I thank all the participants and other people. Thank you one and all.
We'll close the session, sir. We'll sign out. Thank you, sir.
Thank you, sir.
Thank you, sir.